Oh no, that's
Recording in progress.
Are we good?
We're good. We can see it.
So, we can start. Okay,
Yes.
Good morning, everybody. Let me just close the door. Sorry for that mishap. I guess technology is always with us and we'll have to live with it as it is, okay? Yeah, so our morning, the lecture this morning is going to be on diseases of the retina. That's we'll cover diabetes, which is diabetic retinopathy as far as you're concerned, hypertension and its related eye manifestations, HIV and tuberculosis, and a few other conditions that we just run over them for purposes of understanding. So in case I go off air or something, class rep, call me on my phone because sometimes the Wi-Fi goes off and you're not aware as a presenter, okay?
Yes, doctor.
Okay, if you can call me on phone because now you may not know, I may not know I'm off. Okay, let's get moving. So our outline of today, we are going to touch on diabetes, hypertension and vascular occlusions, tuberculosis and posterior uveitis, HIV, CMV retinitis, a little bit on retinal detachment, then after the hereditary conditions of the retina. So at the end of this lecture, you as a student should be able to identify retinal manifestations of systemic disorders, establish systemic control and early referral of retinal diseases, and then conduct advocacy on eye screening for some of these conditions we're talking about, especially diabetic. What investigations for imaging are available for the retina or macula? One is optical coherence tomography, which you can see on your top left there. This shines rays of light through your pupil, which bounces off the retina, and when they bounce back into the computer, a digitized image showing morphology of your retina in cross-section, a tomogram, is presented on a screen. Then we can also do angiography. Dye is injected on the antecubital vein. Then the camera takes photos of the dye as it's flowing through your retina. And then we know where there's a leakage or occlusion of a vessel specifically, okay? Then in this bottom picture, we are seeing what we see in a picture. When you do cross-section of this area, you can see when you have macular edema, for example, what an OCT will look like. And then this one on your right just shows you the different types of angiography machines that we have in the market. So quickly, let's get into diabetic retinopathy. So what is diabetic retinopathy? You know, when you've got high blood sugars over a long time, you destroy your blood vessel walls, and this causes what you call a microangiopathy. In short, you'll either end up with a leakage or occlusion of a vessel. Prevalence of diabetic retinopathy by type of diabetes type 1, 90% are DR is rare at diagnosis. 90% So, what is the pathophysiology of this diabetic retinopathy? Okay. So we have agreed it is a microangiopathy. It affects the blood vessels, small blood vessels all over your body. In this situation, we're talking about the retinal blood vessels. We are lucky it's only in the human retina that you can look into someone who is living and walking without much complicated tests and see how blood is flowing. It's only in the eye retina where you can look at blood flowing through a blood vessel, and this is a very important secret for typing the diagnosis of diabetic retinopathy and the damage to the blood vessels, not just in the eye. If you see changes in the eye, the same is happening in the kidneys, cardiac system, and all that. I want you to remember is you have an arterial, you have a venule, and you've got the connection in between. At that point where you're supplying the arterial side to the venule side to the tissues, you can either have an occlusion mechanism or the blood may flow well, and you, on the other end, have leakage mechanism. Okay? That leakage will lead to edema. If it's around the macula, we'll call it macular edema. Then you end up with abnormal new blood vessels, neovascularization. In a nutshell, that's what I want you to take home. So occlusion causes ischemia, ischemia causes VEGF, and that will cause abnormal blood vessels. Now, these abnormal blood vessels are the nightmare we don't want. They can bleed anytime and cause vitreous hemorrhage, and the patient can become blind. So, on this occlusion side, what do we see physically when you do fundoscopy? The hallmark of occlusion is what we call cotton wool spots. A cotton wool spot on the retina is a sign of the retinal nerve fiber layer being infected. It lacked blood supply, so the nerve fibers that are running on the surface of the retina start dying off with this infective type of necrosis. Then another hallmark is what we call intraretinal microangiopathies, okay? This is what this picture on the left is trying to illustrate, is blood vessels flowing around, okay? We have agreed that there can be leakage. So what do you see on leakage? The blood vessel wall breaks down. You end up with bulging of the wall of the blood vessel like a small balloon. That's called microaneurysm. Then, of course, when they leak, there'll be edema. If you leak out water, it's edema. If you leak out proteins, it's exudates. If you leak out blood, which is hemorrhages. The hemorrhages can be phlegm, continues for long, you will end up with what is called neovascularization. New blood vessels that are abnormal will grow on the surface of the retina. Narrow down on this picture and remember this: if you ever see new blood vessels on the retina, it's not a good thing. This is very advanced stage of diabetic retinopathy, as we are shortly going to classify it. So why do we have to classify the diabetic or grade diabetic retinopathy? There's a study that was done called Early Treatment of Diabetic Retinopathy Study, and they're the ones who came up with this grading. Why is it important to you as a general doctor? Okay, at least you know it's important to determine the eye severity, risk of visual loss. It can be mild, moderate, or severe. Secondly, it is an important pointer to the systemic situation of your patient. From the heart, that's cardiovascular, kidneys, nephropathies, and the brain, neuropathy, the risk of stroke. When you see these changes in the eye, the patient is at risk of stroke. What is the management? How does it help? It helps the ophthalmologist to decide when to do laser, retinal photocoagulation, or any surgery. If they don't have much changes, we usually see them less often. If they've got a lot of changes, as we'll see shortly, we see them more frequently during the year and do laser. Then it's also important for this to tell the physician, hey, the blood sugar control here may not be very good. We need to take some action. So classification. It is classified into, that's classification of diabetic retinopathy. Non-proliferative and proliferative. Very easy. Non-proliferative can be mild, moderate, or severe. Proliferative is if you see any new blood vessel abnormal or any membrane on the retina or any massive bleed, that falls under proliferative. Okay, in a nutshell. Now, what is non-proliferative? What do we actually see on the retina? For the mild one, we see what I told you is called microaneurysm, just outpouching on the blood vessels. This is a mild form. We don't worry too much, but the patient is advised to take care of the sugars and come every 9 months, hoping that it will not advance to the next stage. Now, when do we say it's moderate? It is when you've got the mild changes, that's microaneurysm, plus any hemorrhage, exudate, or cotton wool spots. These ones, we start seeing them more frequently. Now it is every 6 months, twice a year, because 16% of them were found to progress to proliferative stage within 4 years. So you must see them more frequently. What is severe? Severe, we follow something called a 4-2-1 rule. But as far as you're concerned, for you, just if you see so many hemorrhages in all the quadrants, okay, or any venous bleeding, as I've shown you here on this picture, they look like sausage rolls, which are in process being manufactured. Sausage Hello?
Sorry, Doc, we lost you on this slide.
Are we together now?
Yes, yes.
Okay, so you've understood that anybody with severe non-proliferative or proliferative, those are the ones who will undergo laser. Mild and moderate, we do not laser, we just observe them. The frequency is what changes. Are we all clear? Yeah. Because diabetes, you really need to be clear with it. So we have agreed the next stage is now proliferative. So any of these manifestations you're seeing on this picture is proliferative diabetic retinopathy. It is boat-shaped because the top is flat, the bottom is curved. Next is tractional detachment membranes. You can see membranes on the top right picture. The close-up of someone's pupil and iris, you can see this red. This is called rubeosis iridis, okay? Neovascularization of the iris. And these patients come to you with a very painful blind eye. We're just repeating what you have said. Mild and moderate, observe. Severe and proliferative types, you do laser. Down here, you can see the picture of the laser marks. If you ever happen to see a picture with a lot of black spots, don't panic. That is laser done by the ophthalmologist. Anybody who might have more advanced proliferative diabetic retinopathy, membranes, the retina or vitreous hemorrhage, they will need a surgery called vitrectomy because we are eating out the vitreous humor. So vitrectomy is a surgery that we do, and we cut off those membranes. So just in a nutshell, this is what laser means. You can either do it on a desktop. Okay, doctor is here, patient is here, we shoot laser using a desktop mounted machine, or there's this head mounted machine, top right. You can see the head mount machine. what picture you may see in future, do not worry. So the surgery we have agreed is either we are doing laser, we do an ultrasound of the eye to check whether there's retinal detachment. Then we can also do vitrectomy whenever we have vitreous hemorrhage. So what conditions might look like diabetic retinopathy? So one, other vascular diseases such as hypertensive retinopathy, top right, top left. I'll go right, left, right, left. So on the top left is hypertensive retinopathy. This is malignant hypertension. You can't even see the optic radiation might cause cotton wool spots inside your retina that can look like diabetes. Then also branch retinal vein occlusion can look like diabetes. Then sickle cell retinopathy. We are going to talk about this shortly. And the proliferative type of sickle cell retinopathy, you get what is called CFAN neovascularization. We'll talk about it. So we go to the maculopathy. What is diabetic maculopathy? We like to separate the word retinopathy and maculopathy because the macula is a very special area of the retina and sensitive to vision. Anything on your macula has to be given its own attention. So if the leakage of the same mechanism of diabetes happens near the fovea or the macula, as you can see in the picture here, a microaneurysm or a damaged vessel can leak and pour water into the retina under the fovea. We call that diabetic macular edema. That leakage mechanism is also mediated by vascular endothelial growth factor. And this is important when we come to the treatment. We give the anti-VEGF. And you'll see it does wonders. So here we go. How do we treat diabetic maculopathy? Very easy. Long ago, we were giving a lot of laser, either focal laser, as you can see down here, or grid laser, a pattern of dots near your macula. But each time you do laser, you burn photoreceptors and the patient leaves the office with poorer vision than they came with. It fell out of favor. So thank God from 2013, these drugs hit our market. We now inject 3.5 to 4 millimeters from the limbus. This area is called the pars plana, where the needle is. We inject a small amount of drug called anti-VEGF, 0.05 into the vitreous. And you can see on this picture of the serolocity of this patient at baseline, you're seeing poorly. He had this fluid. We go on. By the time he came after almost 1 year, this second last one, you see the edema is already gone. So these drugs are very important and they work wonders. So in a nutshell, you're the ones who do pharmacology. You can remember these are the anti-VEGF medications. They're all antibodies, so they have this MAB in the end of the name, except this one called aflibercept, which is still the same group. So don't need to cram, just know that for treatment, this pathophysiology has VEGF. Therefore, treatment, you need to give anti-VEGF. So now we go to diabetic screening. This means we're trying to go into a population of people who have the disease and we want them to reach the doctor's clinic. So if you do not do laser or screening, it was found that the rate of severe visual loss was very high. When you did screening and laser, the rate of visual loss was low. Okay? This screening is important to you as a doctor because when you'll be going to the community shortly, when you qualify in a few years, you're the one who will have to set up a community screening project where patients come to see the physician. And nowadays, because of COVID and all this, we are lucky we have got cameras that can do, even without dilating the pupil, you can take photos of the retina. And then after the photo is taken, if there's a change, like diabetic retinopathy is seen, you send them to the ophthalmologist. If there's no change, they keep coming for annual review, okay? So it can be community-based or hospital-based, depending on what is there. Any question on diabetes, maybe we'll ask at the end. You can type up, or then I'll reply by email, maybe to the group or something. We'll look for an arrangement of how to address your question. We now go to hypertension and vascular occlusions. I know when I say hypertension, all you want to say because of internal medicine is hypertensive retinopathy, grading 1, 2, 3, 4. I want to start with the more dangerous things that hypertension can cause in the eye before I go to the grading. So I'll start with the vascular occlusions. So one thing you can get in hypertensive is something called central retinal vein occlusion. Why? The venous side of the retinal vein blocks. The artery is still pumping blood. So you get this congested look because the vessels start leaking. You leak either water or blood, okay? So why does this happen? Remember, there's a lamina cribrosa here at the optic disc. You can see I've zoomed in here on the bottom left picture. The lamina cribrosa, this is where the artery comes, accompanied by the vein. It's a very small, narrow space which is very tight. Any small change in the pressures around there can result in blockage of the two vessels. So why does this happen? We all are at an anatomical disadvantage at the lamina cribrosa. Why? Our central retinal artery and vein run together in a common sheath in a very tight space. So what happens as you get hypertension with age and atherosclerosis, the atheromatous artery, central retinal artery, compresses on the vein, blocking that vein, causing turbulent flow, thrombus builds up, and then you get central retinal vein occlusion. Okay? So this is what you see. I've already shown you the picture. In how does the patient present in vein occlusion? Of course, there'll be painless loss of vision. When you look in the eye, you'll see hemorrhages all over, what we call blood and thunder appearance, okay? In all the four quadrants of the retina. Then, of course, you'll have edema also at the disc and the macula. Sometimes, not necessarily only the central vein, it may spare blockage at the central vein, but by the same mechanism, you can block all branch retinal vein occlusion. Sometimes it might affect half the retina and the name changes to hemiretinal vein occlusion. No big deal, it just describes the pattern of the occlusion. Then hemiretinal will cause the next most severe. So who gets central retinal vein occlusion? This is a common question you'll be asked even in internal medicine. So one, just remember vascular diseases, hypertension, diabetes, hyperlipidemia, arteriosclerosis, and people who smoke. Anybody with some vascular disturbance can get central retinal vein occlusion. Two, if you have another abnormality at the optic disc, such as glaucoma, or if you have the disc is tilted or it has what we usually call drusen, a small deposit near the disc can compress the vessel and increase the risk. Then think about diseases that cause thick blood, myeloma, polycythemia, lymphomas, leukemias, and sickle cell can all predispose you to CRVO. Then vasculitis, of course, is a primary disease of vessels where there's inflammation of the blood vessel walls. That happens in lupus, HIV, syphilis, and sometimes herpes zoster and sarcoidosis. For you need just to remember the word vasculitis, contraceptive, diuretics, hepatitis B vaccine, dehydration, and pregnancy. Okay. So how do we treat central retinal vein occlusion? Very easy. Again, laser has lost favor so much, but we still do laser on the whole retina if the disease was caught very late. But the hallmark for the commonest thing is macular edema in central retinal vein occlusion, just like so in the artery, it's easy. What causes the blockage? An atheromatous plaque comes and blocks the central retinal artery. The disc will be very pale and white, and there'll be a cherry red spot at the macula. If you are lucky and you have what we call a ciliaretinal artery, 30% of us have got an interesting artery that runs straight from the optic disc to supply the macula. If you have that, if you look at my bottom, this picture number A at the bottom here, there's a watershed area. These people are very lucky. When they get central retinal artery occlusion, they never get poor vision because the ciliaretinal artery continues supplying them with blood supply at the fovea. But most people, very poor vision, and that's what will make them run to you in the morning. Okay? We have agreed that even the branch of the retinal artery can be blocked. So if it's not at the disc, but out here, like here, you can see a white plaque of cholesterol blocking the vessel. Beyond there, there's no blood supply. How do you know? You can see carefully that the retina beyond that area is a bit pale. So this is a branch of the retinal artery that is occluded. Branch retinal artery occlusion. Treatment of this condition, most of the people usually, luckily, get spontaneous recovery. We have tried ocular massage, sometimes it might help. Anti-glaucoma drops to reduce pressure might help. Vasodilators and thrombolytics have also been found to be useful because of the mechanism. Now to your favorite topic, hypertensive retinopathy. This is a common condition for patients above 40 years. And we use either Skid-Wagner or SKY classification. SKY classification takes care of the hypertension and takes care of the atherosclerosis. Skid-Wagner is the original one, 1958. He described the 4 stages of hypertensive retinopathy. So grade 1, all this is on this one slide. Grade 1, you just have narrow arterioles. In grade 2, you now get what we call arteriovenous nipping. You can see the vein is a bigger, larger, darker red one, and the artery here, where they're crossing, you can see is a bit of a bump, like it nicks away. That is called arteriovenous nipping. In grade 3, hypertension, very easy. It looks like a diabetic retinopathy. Hemorrhages, coronal spots, aneurysms, it's actually called the exudative phase of hypertensive retinopathy. It mimics diabetic retinopathy. Very easy. So for you to remember this, you don't need to suffer so much. Remember only grade 1 is narrowing, grade 2 nipping. Grade 3 is like a diabetic retinopathy. Grade 4 is very easy. There is edema of the disc and macular scar. This happens in patients with malignant hypertension. So what are the other systemic associations of hypertensive retinopathy? You can also get hypertensive choroidopathy. You get some dark spots in the retina. You can get, those are called ethnic spots. These ones are called streaks. There's some streaks sometimes you see there. And you can also get retinal detachment. Then secondly, you can also have optic neuropathy. The edema that we have just shown you in this slide, bottom right, can be persistent and make the nerve to die. So you get optic atrophy in the end, and that's permanent loss of vision. So hypertension, don't take it for granted. Then you can get what is called a macroaneurysm, which can burst and rupture, as you can see in this picture here, A, okay? It's ruptured and bled. This is when you do angiography, this is what you see, the macroaneurysm. Then, of course, hypertension causes stroke, it causes myocardial infarction, MI, and can cause renal damage. We move quickly, we're almost done, to sickle cell disease. Are we together, Mr. Khan? Hello?
Yes, doctor, we're together.
We're together, thank you. Okay, so now we have moved to sickle cell disease. What happens in sickle cell disease on the retina?
Dr. Nyamori, we've lost you. Hello. Dr. Nyamori, we can't hear you, sorry. Could you please confirm? Huh?
Tell me what I'm not doing.
Hello. Dr. Nyamori, please. Just try to mute and unmute. Hello.
Those substitutions of valine and lysine, you know better than me on sickle cell, the traits and thalassemias and all that. Now, what happens in the eye is just like in diabetes, it's classified as non-proliferative sickle cell retinopathy and then proliferative sickle cell retinopathy. Non-proliferative, you can either have tortuous vessels with occlusions, which in this bottom left, you can see there's an area where there is no blood flow. You can get silver wiring. You can see this whitish speckling vessel there. You can get a salmon patch bleed. It's a bleed which looks like a salmon, okay? The salmon color of a fish, okay? It's called a salmon patch, red. When this salmon patch resolves, it becomes blackish, a blackish spot on the retina. It is called a sunburst sign, okay? What happens in proliferative sickle cell retinopathy? Very easy. There's neovascularization. In this case, it is called C-fan neovascularization. You can see on my top right, this plant, is it an animal or a plant in the ocean? This is what it looks like. So the pattern of the new vessel looks like a C-fan. So there are 5 stages. Someone called Goldberg did a lot of research on this and gave 5 stages from occlusion to anastomosis to the C-fan, is stage 3. Then the C-fan can bleed, that's causing vitreous hemorrhage, and it can also cause tractional detachment. Next, we go to autoimmune disorders of the eye. As I was saying before we lost each other, in autoimmune disorders, these patients will come to you. How do you suspect? They'll have visual disturbances, on-off blurring. They can have red eyes, pain, dry eyes, ulcers. They can even have uveitis, present with uveitis, scleritis, episcleritis, and even optic neuritis, or inflammation in any part of the tissues of the eye. So you have to be very suspicious. I'll give you a few examples. In rheumatoid arthritis, these are the findings you might get on the surface of the eye. Ulcers on the cornea, ulcerative keratitis. You can get inflammation of the sclera. It's looking red all the time in particular areas. That's called scleritis. Then it can melt your cornea away. That's the same way you put salt on a snail and it melts away. So the autoimmune process can just eat away the cornea itself, literally, okay? And then it can also eat away the sclera. So this is advanced corneal disease, cornea melt. Advanced scleral disease is called scleromalacia. The disease melts away your sclera. What happens in diseases such as lupus? What do you see on the retina? In lupus, you will see what is called perivascular sheathing. These white areas have put arrows on them, on the blood vessel. If you see anything like that, it's a hallmark of what is called vasculitis, perivascular sheathing. The inflammatory material is deposited on the sides of the blood vessel. It's like a river that flooded and then receded and left sand on the sandbanks, on the edges, okay? That is the inflammatory debris you're seeing, the white stuff. If you do an angiograph, you'll see there's leakage along those areas where there is perivascular sheathing. It glows up when you do fluorescent angiography. Then, in a condition called giant cell arteritis, we get a condition called anterior ischemic optic neuropathy. Of course, they have that prominent temporal vein on their head with a lot of headache, and they're usually old men, very common. What will you see on the fundus? This you'll need in internal medicine. You get optic disc edema. Interesting optic disc edema. Why is it a special one? Because it is pale and not hyperemic. So it is described as pallid disc edema. Classically, when you're seeing disc edema, we tell you to say it's hyperemic disc, swollen, all that. But in this case, it's not pink, it is white but swollen, paradoxically. On angiography, you'll of course get delayed filling of the choroid as well as the retina because it is at the larger vessel before it has reached the eye. In cancers that you're going to be seeing soon, you can get retinal diseases. Which cancers do you have in the eye that are relevant to you? Retinoblastoma, melanomas, squamous cell, basal cell carcinomas, and of importance at your level, please, breast cancer and prostate cancer can metastasize to the choroid. I've given you two pictures here of a CA breast with choroid metastasis. You can see this yellowish area. And on the right, you've seen what a choroidal melanoma looks like. Of course, it's black because it's pigmented with melanotic cells. Okay. Then even Burkitt's and the orbital diseases can also have manifestations on the retina. So we're going to go to uveitis, tuberculosis, and HIV, okay? The uvea, the term uvea refers to the iris, ciliary body, and the choroid. When you say uveitis, is either one or both or all these are affected by some inflammatory condition. There are so many causes of posterior uveitis, but what is important at your level maybe to highlight, I wanted to mention TB because that's what you're committed to discuss today. But there are many other causes I don't want to dwell on them. So, what are the classical features of posterior uveitis? So, remember, we have a retina, we have a choroid, and we have blood vessels. So, each of them just add itis because they get inflamed during uveitis. So, in the choroid, you'll see choroiditis, like these whitish lesions that are very deep inside the retina. On the retinal surface, you can get retinitis. You cannot see through that layer. Then on the blood vessels, what I've just mentioned is called perivascular sheathing. I've given you a very nice picture here. You can see the blood vessels are looking whitish on the edges, but blood is still flowing. So this is an inflammatory condition causing inflammation of the vessels, vasculitis. If the veins are the ones affected, it's called periphlebitis. And if it is the arterial side, it's called angiitis, okay? Then the choroiditis can also take the form like the shape of a snake, like there's a snake in the retina, that is called serpiginous, like a serpent, okay? So tuberculosis, what does it do to the posterior segment? What do you see? 80% of tuberculosis affects the lungs, 20% other organs. So most of the TB you get is pulmonary. Remember, there's another quiet group of 20% who are not having pulmonary but have extrapulmonary. On this extrapulmonary TB, posterior uveitis is the most common presentation. Remember, absence of pulmonary TB does not tell you that cannot be systemic or ocular TB elsewhere. The two are mutually not exclusive. You always have to look independently for systemic TB and independently for pulmonary TB. So what you see on the eye, tubercles in the choroid, sometimes even granulomas, which are tuberculomas, and then on the retina, you can see neuroretinitis. Sometimes pus can fill the whole of the vitreous, that is called endophthalmitis. And sometimes the endophthalmitis can affect the walls of your eye until they melt away. It is called panophthalmitis. The picture below is showing you active choroiditis. Then when it heals, and then you can have multifocal lesions as well. Next, you can also get this snake-like pattern, as I've said already, serpiginous choroiditis. This can also be seen in tuberculosis in very endemic areas. So how do you manage this? It is nothing different from the TB that you know. It's the standard 6-month therapy as per WHO. You may have to add steroids like prednisolone. And then if there's a lot of damage and bleeding you might have to do, the only extra thing you might send for us to do is laser photocoagulation. The tests and everything else are the same as what you know for TB. You may do skin tests, quantiferon gold, PCR, chest X-ray, and an angiography may be necessary to look for leakages or new vessels. Are we still together, Mr. Khan?
Yes, we're all
Hello?
together now.
Okay. I go now to HIV. We're almost done. In HIV, ocular complications, they're classified into vascular, infectious, tumors, and neurological. Very easy, okay? So that is how we classify the diseases. This is more of reference material. We are not going through this list in detail, but just remember, if you're asked HIV, how do you classify it? There's vascular, infectious, tumors that they get, and then neurological. And then there's some conditions which correlate with the CD4 count, which nowadays that is not being done routinely, but you can ask for it. Of these ones, I need to mention to you, CD4 less than 100, the commonest condition you'll see in our setup is cytomegalovirus retinitis, CMV retinitis. And then you may see the others, because the others can happen even when CD4 is above 100, okay? What do you see on vasculopathy? It can be small vessels, called microvasculopathy, okay? On the conjunctiva. Then on the retina, you can get what is called HIV retinopathy. Quiet, discrete, sharp edge of cotonal spots all over the retina. Then you can get large vessel disease, which as you can see here is vasculitis. And then you can also get vein occlusions. And then you can also get the perivascular sheathing we've talked about, okay? So you can get a picture like the ones we've talked about of occlusions, vasculitis, and then on this other side, you can get cotonal spots. So remember, these patients, as they're taking, when their CD4s are less than 100, they have no immunity. They cannot even mount a response and cause inflammation in the eye. They rarely get uveitis. When you pick the CMV retinitis and send them to the CCC to go and search ARVs, the immunity starts rising up. Now they're able to mount inflammatory. They start having commonly uveitis-like conditions as they're recovering. Therefore, what will happen is the incidence of HIV-related CMV retinitis has gone down. So in your situation, you not meet them in the field so much than maybe 10 years ago. But what you'll now see more is the effect of the compliance on heart, whereby they get inflammatory conditions, okay? If you see anybody with CMV retinitis in the modern times, it means they are not taking their antiretrovirals, or they have not started, or they're having resistance. It's a very strange thing to see in modern times because people are taking heart. The new clinical signs in treated patients is what I've described as it is called immune reconstitution syndrome or immune reconstitution uveitis. So you'll treat them and start running back to you, doctor, now I'm having a red, painful eye, fearing light. They're having uveitis. But that's, in quotes, a good sign because the immunity is picking up. So CMV retinitis, this is what we see. It can be a granular appearance on the retina. You can get hemorrhages and necrosis of the retina, like this one. Then you can get angiitis, inflammation of the either arteritis or perifibrilitis, inflammation of the blood vessel walls, like a frosted branch. Okay. So quickly, to highlight the retinal detachment, there are three types. They could be either phlegmatogenous, the ones which have got a tear. We're finished with HIV, so we're talking about retinal detachment, okay? So you can have phlegmatogenous retinal detachment where there's a tear. You can have tractional detachment whereby there's a membrane that is pulling the retina up, or you can get exudative retinal detachment whereby there's fluid pushing the retina from below, or combinations, okay? Phlegmatogenous, the types of tears you see in an eye all take a horseshoe pattern, okay? They tend to be either round or curved. And if you ever see someone with a retinal tear like this one at the bottom here, you see fluid will enter through the hole into the back of the retina. Like the tube of a car tire, the retina will fall off and they become permanently blind. So we have to rush them to theater within 2 weeks to go and do what? Vitrectomy. We suck and eat all these vitreous out to the machine. And then we laser around this hole and retina and put gas on the retina, okay? So people who have got retinal detachment, please, if you suspect anybody with retinal detachment, please send them. How do you suspect? What is important to you? Remember, floaters, they see things flying around, flashes, they think they've seen lightning. When you're getting a retinal tear, because your retina is sensing light, you'll get a flash of light, okay? And then, of course, because the retina has fallen off, they'll see a scotoma. That area where the retina is falling off, they cannot see through it. So they'll say there's a curtain in front of them permanently when they walk, okay? The tractional detachment is different mechanism. This happens like in diabetes. We've talked about diabetes, sickle cell retinopathy, and retinopathy of prematurity. Any condition with membranes of the retina can pull your retina up and cause tractional retinal detachment. Treatment is the same, vitrectomy, and we cut off the membrane. Exudative detachment, this is simple. Any inflammatory condition or neoplastic condition on the retina will cause fluid to ooze out under the retina and lift it up. In this case, there's no tear, there's no membrane, and the detachment tends to be raised and smooth. When these detachments resolve over time and they flatten out, they form what you call a leopard spot pattern. If you treat, in this case, we do not do any surgery for the eye. Remember, the primary condition is inflammatory. So this is a medical disease treated by physicians. So when you pinpoint the cause of the inflammation and you start treating, when the detachment goes and you come back and do fundoscopy, like after 2-3 months, this is what you'll see. The pale retina with dark areas of RPE, where it has reattached back. Finally, almost there. The other disease to just highlight is called age-related macular degeneration. It's more common in whites than we blacks, and it affects very old people, usually 75 and above, and commoner in people who are less pigmented, okay? The retina and the retinal pigment epithelium starts leaking fluid under the retina, and you can get detachment of the retinal pigment epithelium and the retina with distortion of blood vessels. Here is what they see. I've given you a normal face. When they start having retinal detachment, the retina gets distorted, it gets wrinkles, so they start getting images which are distorted. When they look at someone, this is what they see. Then when the distortion increases, they get blurry vision. When they now start bleeding or forming scars, they get a total scotoma, meaning they cannot see through that area. Two types of AMD, age-related macular degeneration. If they bleed, it is called wet, bottom right. If there's no bleeding, just this granular appearance, we call it dry type AMD. Okay, the wet type is worse than the dry type because it leads to rapid loss of vision. Dry type, we only treat them by giving multivitamins. Wet type, they need to be given anti-VEGF injections because the mechanism is of new blood vessels under the retina, just like they said in diabetes. Then finally, I'd like to highlight two retinal diseases that are hereditary. You know very well about albinism. So when you do fundoscopy on albinos, you'll find they have a very blonde fundus. And then there's no clear fovea. You don't know where the macula is because there's no pigment, the xanthophyll pigment that is supposed to be at the macula, okay? So they usually have photophobia, nystagmus, refractive errors, then hypoplasia of the optic nerve and disc. And then you can see the choroid vessels because they have no melanin. So you're seeing these lines below are the choroidal vessels under the eye. There's a very blonde fundus. In retinitis pigmentosa, what you see is the opposite. You have a normal retina, but they start forming dark, what we call bone spicules, okay? Dark deposits. As they get older and older, the dark deposits continue increasing until they start involving the macula by around the age of 18. By the time the dark spots reach the macula, unfortunately, these patients have lost vision. And so far, there's no treatment for retinitis pigmentosa. We are trying gene therapy, but we have not gotten anywhere so far. So unfortunately, we have to send them for rehab to either here at the Kenya Society of the Blind or to a low vision therapy clinic. They start using the white cane and braille and all that when usually they've gone so much. And also, you need to inform the relatives about the disease that these patients will not see in the dark because it affects the rods and not the cones. So they have very poor night vision in retinitis pigmentosa. So the household should have very bright lights and minimum furniture in the center, like of the sitting room, so that these guys don't bump into structures that are in the center, okay? Thank you very much, Mr. Khan. I think I will end there. Sorry for the small mishap, but I think I've kept to my time. Hello, Mr. Khan?
Yes, Doc.
I hope
Thank
you
you.
Well. Yeah. Any questions or any concerns?
No one has posted in the chat box.
Yes.
But if someone has a question, can I share with them your number or email?
Yeah, what you could do,
Yes.
somehow have a session where you have all those questions piled up, send them to me, then I'll respond to each on an email, then to be fair to everyone, isn't it?
Okay, that's good.
And then also we arrange for a PDF, because I know sometimes these things are very difficult to handle at home, people don't have network and all that.
Yes, Doc.
Okay. Thank you so much. I hope it went well and we could hear each other.
Yes, it was okay.
Yes, any questions or suggestions on your part?
No, I think we're good. I appreciate your time. Yes, it's okay.
I think I better let you go, because it's now 9 a.m. I believe you may be going somewhere else. And please, those who will keep coming to the rotation, when you come to the rotations of posterior segment, we'll again re-emphasize these things. So make sure you be on point, so that I'll give you a patient we see, and then we integrate all these things for the days of your graduation. Okay?
Okay.
Yeah, so we'll go more slowly in a session of tutorial of posterior segment clinic, isn't it? For each of the small groups. So do not worry. Yeah. Thank you very much for your patience. All the best. I'm seeing you had how many? 283 only. Wow.
No, people are leaving.
Encourage people.
We were around 380.
Okay.
On average.
Thank you.
Yeah.
Have a good day.
You too, Dr.
Stop
Nyamori.
sharing. Okay.